This is part of a group of visitors who are part of an exchange from Ben Gurion University in Israel that's funded by the Socialized program at UCLA. Over the years, there have been a number of academic teams that have gone back and forth between the two institutions. And this particular exchange focuses on the urban geography of health and migration. So all of the participants, both at UCLA, and we've had a number of people from both North and South Campus, as well as the visitors from Ben Gurion University, are very interested in migration, the migration process, its impact on health, access to health, the social construction of immigrant status, and how place and space impacts all of these. So today we're going to hear from two of the researchers from Ben Gurion University, and excuse me for not giving the names the perfect pronunciation, but Nadav
Davidovitch.
Davidovitch?
You need to start Davidovitch.
Davidovitch, okay. Go up the hill. Is an MD, MPH, and PhD, so he has lots of initials after his name. And with training in epidemiology and history, as well as sociology of health. And he's a senior lecturer in the Department of Health Systems Management, Faculty of Health Sciences, Public Health as we would know it here, at Ben Gurion University. He's also chair of the Center for Health Policy in the Negev. And Dani Filc is a senior lecturer in politics and government and at Ben Gurion University, and a board member of the Physicians for Human Rights, and they're both involved in a immigrant clinic in Israel and have been doing research in this area for a number of years. And we're going to talk about something that we have been experiencing as well in the United States, which is the privatization of healthcare, but coming from a universal healthcare system.
Thank you very much, Steve. And we really want to say that it's a wonderful experience for us. We've been taken care of in such an amazing way. Also learned a lot and met all the new friends. So it's really lovely. So thanks a lot. I'll start a bit with some context about Israel. When I was a child, Israel was about 3 million people. Now it's almost 8 million people. Here you have the data from 2003. You can see that we have also minorities. Of course, our minority is the major one. We have Muslims, Christians, Druze. And here you can see the changes between the 80s, 90s, 2000. Now, 2011, we are almost 8 million people. So it's quite dramatic. And of course, migration is one of the issues, but not only. Also, fertility rates is quite high, but migration is definitely the most important factor. And this is we've been discussing in the last two days. You can see migration. I mean, the topic today is not migration, but I wanted to bring you you can see the different waves. This is the last one with about 1 million immigrants, mainly coming from the former USSR, coming to Israel. You can see the average population growth, which is quite impressive, I guess. Some macroeconomic indicators. I think that in terms of the budget deficit, comparing to the United States, the budget deficit right now, Israel now is a relatively good economic state. You can see unemployment. I think now it's even less. It's about 6.9 or something like that. But unfortunately, in terms of the Gini coefficient, and maybe Dani will speak about it later, and poverty rates, these are things that are... So we are improving, but the gaps, the social gaps are getting bigger. Some, again, population demographic indicators. You can see the fertility rate, which is quite high. It is higher among our population, also in ultra-Orthodox. Again, the immigrants are arriving. In terms of population 65 and above, you see it's about 10%. Comparing to Europe, for example, it's lower. I think the age distribution is a bit more similar to the United States and to Europe. And some health indicators, you can see, for example, life expectancy. Now this is for 2004, but now life expectancy is about 82 for women and about 79 for men. You can see infant mortality rates that from the 70s got really down. Here in these graphs you can see it even better. This is life expectancy by gender. Of course, regarding question of health inequities, so if you're comparing Israel and Arabs, there are gaps that even increased in the last couple of years. This is the trends in infant mortality rates, and also here the same issues of health disparities between Jewish and Arab population. We are situated in the Negev, Ben Gurion University. We have, of course, also have inequities regarding center and periphery, and the research center that I'm chairing is the main focus is on health inequities. National expenditure on health, this is from 1999, but it's about the same, around 8%, which is about the EU average. This is from 1999, so US was then below 14%. Now it's even, I think, more than 60%. It's another topic, of course, also relevant to the question of privatization that we'll discuss later. Okay, so some historical context. I will speak until the enactment of the National Health Insurance Law in Israel, 94, entered into it was active in 1995, and then Dani will continue with what happened since the law. So it's very interesting to see the American influence on the Israeli healthcare system, and you'll be very surprised maybe, because actually, if you're going back immediately after World War I, Hadassah Medical Organization, an American organization, they brought American science, they brought American way of management, but they brought with them a very strong ideal of social medicine. Max Rubinov was chairing this delegation that started as a relief operation, and then they remained in Israel. And initially they had the ambition to run all of the health in the country. We're talking about the British Mandate. The Zionists are building their own institution, what they consider as a pre-state. So Max Rubinov was one of the pioneers. He, a Jewish physician coming from Eastern Europe, working in Lower East Side in New York with Jewish immigrants, and also was involved in many campaigns, especially in New York, for having health insurance. For those of in American Journal of Public Health, there was an article published by Ted Brown, and after he failed, he went to the promised land to have a new experiment, maybe. So Hadassah, although coming from the United States, had really strong social medicine orientation. Okay, they were against private medicine. Every physician that was involved with the Hadassah Medical Organization could not work as a private physician. And there were even stories about a physician that was caught in a hotel giving private, it's almost like a prostitute, and he was expelled immediately from Hadassah Medical Organization. The other important institution, and again I'm doing it in a very superficial way, was the General Sick Fund. The General Sick Fund was actually established already in 1911, but only after the World War I. Stemmed to be an important organization. This was an organization that was related to the worker union, and later on also related very strongly to the political party of Mapai, that later on will become the Labour Party. And the connection was so strong that if you were part of the workers union, automatically you needed to be also a member of the Sick Fund, and vice versa. And after, to make the long story, and they were also, of course, very much into social medicine, also against private practice. So these are very important it's a very important historical context, because if you're talking about the US and in Israel, so we started just from the opposite direction, and you see by then the sad story that, I don't know, maybe it's like airplanes that are going to cross each other, but this will be the story that Dani will tell you later. So we started with as a very strong social medicine orientation. After Israel was established, of course, we had the Ministry of Health. The General Sick Fund was acting behind the scene almost as a second Ministry of Health, because the Labour Party was in power for 30 years until 1977, when the Likud entered into power. And in many, many ways, actually the General Sick Fund was very much involved in health policy. We had many failed trials to have a national health insurance law. What is interesting in Israel, that in 1953 Israel passed a social security law, and the health insurance law was supposed to be part of it, but because of the General Sick Fund and other, including the Israeli Medical Association, not surprisingly, like here, but the Israeli Medical Association at that time was a relatively very small and not important organization, so they were against it. And finally, David Ben Gurion and the Prime Minister had this idea of taking all of the different hospitals and actually turning it as similar to the UK system of nationalizing the healthcare system, also the hospital, etc. So it failed in '53, it failed again and again and again. So Israel, until the enactment of the law in '94, actually it was a very interesting system. I don't know any other equivalent one, in terms that although it was voluntary, more than 90% of the populations were insured. And to make a long story short, finally in the 90s we have 4 sick funds. 2 of them heavily related to political parties. One is the General Sick Fund, the other one is Leumit, was related to the Likud, and 2 others, one Maccabi that started in the 40s with the German Jewish physician immigrating, and they didn't like this, they wanted to have their own practice and to have a different relationship with the sick fund, unlike the General Sick Fund. And Meuchedet, that's another story, but we have 4 sick funds. People are voluntarily insured, more than 90%. Of course, there were difference of coverage among different populations. So I think in our population it was more about 70%. And this is the system just before the enactment of the law. During the 80s, like in any other country, we have major crisis stemming from the rise of technology, medical technology costs. We have entering the language, I'm coming from the health system management department, so you know the managed care kind of ideology is developing. And what is really important to say also, that there was a huge physician strike in 1983. One of the strikes that actually built the power of the Israeli Medical Association. We actually have now also a strike, but that's another story. Maybe Dani will say a few words about that. And there was a sense of crisis, that's for sure, in the 80s about the medical system. We're talking about public hospitals that didn't have enough money to invest in new technology. We have the so-called patient third clients, not yet, but about to turn client that dissatisfied with the system, long waiting lines. And in '88, we have a commission, a parliamentary commission, the Netanyahu Commission, not Benjamin Netanyahu, but a judge. I think he's his aunt, no? Yeah, but no conspiracies. So we have the Netanyahu Commission, and this is the way that the Netanyahu Commission defined the problems. Maybe not necessarily how we define the problems. We'll see maybe later. We're talking about inadequacies in the service provided to the public, Ministry of Health dual role as service provider and regulator, something that is true also today, vague financing and budgeting procedures, suboptimal organization of the system, lack of managerial tool, and low levels of employee satisfaction and motivation. And in 1990, the Netanyahu Commission actually, they are publishing the recommendations. One of the Netanyahu Commission actually is Professor Dr. Chernyakhovsky in our department. And they had many recommendations. One of them is legislation to introduce the national health insurance law. And finally, maybe this was the only recommendation that was fulfilled. And also it took several years to fulfill this recommendation, because they had also a recommendation about reorganization of the Ministry of Health, having the districts as acting as almost a mini Ministry of Health on the regional level, and this happened only partially. Regionalization, decentralization, the question of managed care and competition was already there. Centralized financing system, capitation payments, things that also was introduced, but with many quarrels about what kind of variables should be entered. And finally, the only variable that was introduced was age. Recently, it was changed a bit. Maybe we'll talk about by the end. But it also said how, again, the system felt that it was in crisis. Okay, so it was a crisis, but also there was a perception of crisis. And I think it's relevant also for the US context, that I think there was a crisis for many years, but it's interesting to see how recently it was not only, academics talking about crisis, but also you can go to the man in the street, and there is a sense of crisis. Maybe the solutions are very different. But so also in Israel in the 90s, we're talking about a crisis, but also it is being perceived as a crisis. And then we have here, I'll do it very simplistically. Finally, in '94, after several years of negotiation, we have the National Health Insurance Law. It was a window of opportunity, and since historians really hate this question, what happened if, but it seems to me that if there was not a law enacted in the 90s, I'm not even sure what will happen today. Of course, the question of money, the budget issues is very, and there were several reasons why these windows of opportunity. Some of them are related to the way that the Netanyahu Commission was perceived as a professional commission and not political one. They framed the language in the language of the rising field of health policy or health system management. They didn't speak like other previous committees necessarily about the political relationship between the General Sick Fund and the Labour Party, things that was always behind the scene, but they presented it as something more professional. Also, they brought models from different countries. So there were precedents, for example, about the capitation payments and etc., bringing models from the Netherlands, from the UK, it was also very persuasive. But also in the political sphere, we have those days the Rubin government, Yitzhak Rubin government, and we have Shohat, who was then the Minister of Finance, that he was, I think, the only Minister of Finance that was actually supporting. I mean, the Minister of Finance had some criticism, but they were supporting the law. So finally, the law was passed, and the main political issue there was actually disconnecting the political tie between the General Sick Fund and the Labour Party, and this was a major thing. But of course, nobody now even too much. Younger generation, my kids, it would seem to make them crazy that you needed to be in the worker union and be also in how it relates to politics. So now, of course, we are left with the law, and maybe now I'll move to Dani. And of course, the law, just one sentence, the law in many ways. One of the issues was related to reducing. It reduced health inequities, especially in the Arab population. More people were now insured. And we had the national health insurance law that actually every citizen or every legal resident in Israel is actually entitled for health insurance. They left the 4 different sick funds, the historical sick funds, they left them. They established a kind of a managed care competition with a capitation formula. And now we'll move to Dani. I don't know if you want to use this slide or...
Thank you, Nadav. The main points of the law, indeed, what it did was to modify the system which was a social security system, more like the German one, or a corporatist system. It was transformed into a universal healthcare system with a single payer, with the state as single payer, but with 4 different providers. The difference between the NHI and the UK system and the Israeli system is that in the UK system you have a single payer system and also a single provider. In Israel you have a single payer and 4 different providers. The 4 providers function like non-profit HMOs in the United States. They are funded by an earmarked tax which amounts to more or less 5% of income. Until 1997, this was complemented by a employer's tax, which was something like 3% of the employee's wage. And the state also paid, apart from general taxation, for preventive medicine and for mental health medicine. The money was divided between the sick funds according to a formula of corrected capitation. It corrected the number of people insured by each of the sick funds by the age, by an age factor, taking into account that age is the main variable in concerning to utilization of healthcare. So this system of universalization of healthcare indeed made the system much more equal, since all the 100% of the population was insured. The system detached between ability to pay and entitlement to health care, because for every citizen, even every legal resident in Israel was entitled to health care, independent of the fact that he or she contributed or not contributed to by paying the health tax. And the second point, it made the incomes of the 4 different sick funds and the per capita health expenditure of the 4 sick funds much more equal than before the law. The law doesn't allow for cream skimming, because the sick funds must receive any person wanting to be enrolled into that particular sick fund, and twice a year every citizen has the possibility to change sick funds. Indeed, the percentage of people shifting from one sick fund to another is very, very low. Less than 5% of the people have shifted sick funds. The degree? Yeah.
I'm sorry, quick question. If someone couldn't pay for the house tax, what happened?
He's entitled, not paying for the tax. There is a complete detachment between ability to pay and entitlement to. If a person is considered by the state as a legal resident, he or she has entitled to care independently of ability to pay. So an unemployed, for example, pay something like $10 a month, which are deducted from their from the unemployed pension. So there is no legal resident which is not entitled to treatment. So this is a universal system which during the 2 or 3 first years worked very well. It even since the beginning of the law in 1995, the percentage of the GDP, the health expenditure as percentage of the GDP went down, even though insurance was enlarged. So it was the law was completely win-win situation. It was more equal, more efficient, and less expensive. The problem is that the law didn't fit with the general trend of neoliberalization of the Israeli society and neoliberalization also of the welfare state as a whole. So this win-win situation held up for a couple of years. In 1997, the employer's tax was eliminated as a way of, a supply side kind of economic vision, that you must make jobs cheaper for employers, so the employer's tax was abolished. In 1998, co-payments, significant co-payments were included. So, and this began a process of privatization of healthcare within a universal healthcare system. This is not privatization in terms of U.S., but it was really significant. In 2010, Israel is, from all OECD countries, the fourth worst distribution between private and public financing of national health expenditure, after the States, South Korea, and Mexico. Now, Israel is 58% of the national health expenditure is privately financed, and only 42% is publicly financed. Also, it has the highest, after South Korea and Mexico, the highest out-of-pocket financing. 30% of the national health expenditure is financed out of pocket. And the queer thing, if you want, is that this process occurred within a single-payer universal health system, which, and that this is a process completely opposed to the spirit of the national health insurance law. This privatization of healthcare has three different dimensions. The first one is privatization of financing. The second one is privatization of the provision of services. And the third one is, you could consider it as the privatization of the organizational culture of public healthcare organizations. That means that public healthcare organizations, both the sick funds and public hospitals, adopted an organizational culture imported from the business sector and began to act and to decide questions of resources, the way to distribute resources, and even the organizational language. They began to speak the language of the business sector. Patients became clients, and physicians or nurses or healthcare professionals became providers, and the organizational culture was an organizational culture of internal markets and not of service provision, as it was traditionally in Israel.
Quick question.
Yes.
Did the costs go up a lot once they started switching on a percentage basis on the overall GDP? Or
No.
what happened to the overall cost?
No.
The cost didn't change much.
The cost didn't change much because there is still, because it's still a universal healthcare system, the state has the possibility of relatively controlling costs. So it's still 7.9 from the GDP, and what has happened is a shift from public financing to private financing. What has happened is that during the 15 years since already more than 16 years since the legislation of the National Health Insurance Law, the real value of the state per capita investment has decreased in 30%. And this has been covered by private and semi-private schemes. And one of the problems of the Israeli system nowadays is the blurring of the boundaries between the private and the public sector. That means that, and there is a blurring of the boundaries at every level. The public sick funds, the 4 public non-profit sick funds, sell semi-private insurance to their members insuring them for services not provided by the public system. They pay for surgical interventions done at private hospitals by doctors who worked during the morning at the public system and after hours at the private system. So you have private hospitals, public employees with semi-private funding. The blurring is making, and there are a lot of conflicts of interest concerning this blurring of limits. There are public hospitals which sell services which are not included in the public healthcare basket to the semi-private insurance schemes of the public sick funds. And now the doctor strike, the physician strike that Nadav mentioned, one of the things they would like to have enacted is the possibility for doctors to work private within public hospitals. And so there is a complete blurring of the limits between public and private, which means an increase in inequality of care, inequality in access of care, problems of regulation, ethical problems concerning conflicts of interest, but in the meantime, it has the political advantage from the point of view of the government that it, in a way, decreases the degree of public unrest because of the constraint of public funding, because with mostly the middle classes find in the complementary insurance schemes a solution that doesn't require political organization against the constraint of public funding. Now, this slide shows the growth of out-of-pocket payment and the decrease of government funding until the enactment of the National Health Insurance Law. And this is the increase since the enactment of the health insurance law, the increase in copayment percentage of sick funds income. The copayments, which were relatively insignificant in 1995, relatively grew. This is 2002. Now it's already 13%. Those are, the national health expenditure in Israel by financing sector. In 1995, with the enactment of the National Health Insurance Law, it was 75-25%. It was quite similar to the EU distribution. In those years, the EU distribution was 80%, 20%. But in Israel, dental health is completely private, and dental health is some 9 to 10% of the national health expenditure. So if you take that, it would be almost similar. But as you can appreciate, there has been a significant decrease in government financing and a concomitant increase in household financing. This is 2008. As I told you, by 2010, it was already less than 50% publicly financed. The second trend of privatization, or the second expression of privatization, is privatization of provision. And also here you can see, this is before the enactment of the law, that the business sector steadily increased. The non-profit, non-governmental remain the same, and the governmental authority and the public sick funds relatively decreased. After the enactment of the law, things get even worse. You see that now the government, which provided 22%, now it's providing just 5.8%. The SIG funds decreased from 43% to 33%. Non-profit sector decreased, and the business sector increased significantly. Now, I should say that here in 2003, we have a kind of methodological artifact which explains some of the change. Because since these are data from the Central Bureau of Statistics, the Israeli Central Bureau of Statistics, in 2003, the Central Bureau of Statistics decided that they will consider like business sector also services offered by government-owned administration, but functioning by market criteria. So not all of this business sector is privately owned, but it functions by market criteria and not by public sector service provision criteria. So, but we don't have, since they are the only source of information and they change the way in which they inform, we can't have real comparative measures. But I think that it's not only methodological. The fact that the real point, or the important point, is that even government and SIG fund owned services are functioning like the business sector in terms of deciding who gets what and who provides what. Yes?
I guess I'm not exactly clear the difference between business and the sickness funds and nonprofits. So we don't really have the same distinction here in the U.S. So could you clarify that, please?
Yes. Sorry, I will go. The SIG funds are those 4 HMOs, non-profit HMOs, who are financed mostly by government monies providing from the earmark tax and by co-payments. And they are insurers but also providers. They are like HMOs, like Kaiser Permanente. They are like the Kaiser Permanente model. The difference between the Kaiser Permanente model and the SIG fund model after the legislation of the National Health Insurance Law is that they are financed by the government, and they do not have they take co-payments, but they are not paid directly by their members. The members pay to the government as a tax, and they receive the money from the government. Those are the SIG funds. Non-profit organizations are hospitals, like, for example, Adasa Hospital, which are providers of services. They are paid by the SIG funds, usually in terms of diagnostic-related groups, or with a capping system. The forms of payment are complicated because it's the combination of diagnostic-related groups with a per-day payment, but with a capping. If the SIG fund paid a certain amount, they won't pay more, even if they use more services. This in order to disincentive overdoing and by hospitals. This is the non-profit sector. The government sector are mostly hospitals owned by the government, also selling their services to the SIG funds. And then there are the business sector, private labs, private X-rays, private MRIs, and more private hospitals. The main thing that explains this is the development of a flourishing private hospital sector selling services to the semi-private insurance schemes marketed by the sick funds. And today, in 2010, the private sector, the biggest private hospital, which is called the Asuta Hospital, does more surgical procedures than the biggest public hospital in Israel. And this is relatively new. There is a perverse incentive because this private hospital does usually profitable, simple procedures like hernia or usually minor surgery, while the more expensive surgery, which requires more days staying in hospital, high complexity, this is still dumped into the public system, even when there are patients which are operated at the private sector and they suffer from complications, they are shifted to the public sector. So there is a kind of indirect subsiding of the private sector by the public one.
Dani, I want also to add, because it's different than in the US, that the public hospitals are those who are affiliated to universities, and they are the more prestigious. So it's almost in terms of professional career, or so a professor would like to have a position in the public hospital, okay, and maybe do some extra money in the private one. But it's important. So, for example, the Israeli Medical Association, they are the great supporters now of having this strange combination, strange for Israelis, maybe not strange here, of private-public mix, because then they can enjoy all worlds, because they can have both the prestige, and the research and academic ranking, etc.
And job security.
And job security, but also doing work in the private. And of course, it's a conflict of interest, but also conflicts in terms that in Israel, physicians are not passing how do you call it, like a card for...
There's no real control how much time they remain in the public system.
But yeah, there is no time card, and this is one of the... If you are going to the Israeli Medical Association, you're just bringing this, thing about the time card, and they... I don't know what is the situation in the United States. Physicians need to punch a card?
In public hospitals, they actually do. And some physicians at Martin Luther King Hospital here in Los Angeles were doing exactly what you're talking about. That is, they were claiming hours of pay for work in the public hospital, and their timesheet showed that. At the same time, they were working at a private clinic up in the Antelope Valley collecting private fees, and they were fired, and it was a very big controversy.
So in Israel, it's almost the norm. Of course, if there is a major operation and someone will... There were some physicians that were accused and even went to jail. But the norm is that usually at about 2-3 you are moving to the private hospital and you're on call.
So there is a lot of that, but what's not allowed, and is considered not just a conflict of interest, but corruption, sure, is collecting fees for both time, for the same hour that you're being paid by the public hospital and spending it collecting fees.
So that is one of the problems with that distribution. Now, the third type of privatization is the privatization of the organizational culture. More and more, the public system began to behave as a business organization. Also blurring the differences between what is to give a public service and what is to make business out of providing a service. And examples of that trend are the fact that public hospitals have built private hospitals within the public hospital. For example, one of the biggest public hospital in Israel, which is called Tel HaShomer, they have within the public hospital a private hospital selling cosmetic medicine. And that is one example. A second example is the Tel Aviv hospital, which is owned by the city council. Has two different kind of hospitalization for women who gave birth. You have the common rooms, which are public, and then within the same hospital, you have a floor, which is called the hotel, where women who pay an extra fee are hospitalized in 4 stars or 5 stars hotel conditions. And the problematic point is not only that this private facility is owned by a public hospital, but that public doctors paid by public money leave the floor in order to go to check the women in the semi-private facility. So there is a completely blurring, and once again, a kind of perverse subsidy of the private services by the public service. The same kind of thing happens at the level of the sick funds. The sick funds are public and paid by the government monies. They sell a lot of private services, like, for example, alternative medicine, cosmetic medicine, drugs which are not included in the health basket because are too expensive or because there's no clear advantage over existing drugs, and they are selling them or through a semi-private insurance scheme or directly as an out-of-pocket service. So, and probably the worst thing is that in order to make ends meet, the sick funds facing limited government funding began to plan the services in order to attract a more convenient constituency, in order to improve the age mix. And for example, I will give you one of the most perverted examples of this kind of thinking. They have developed 2 queues for people who came to blood tests. One for older people who have, in the eyes of the sick funds, more time, so they can wait, and a VIP system for younger working people that get attended before. Now, in terms of medical need, this is an absurd, because for old people it's much more difficult to wait without eating if they are going, to have a blood test, testing glucose or cholesterol, than for younger people. But from the point of view of a business-like organization, they want to appeal to a younger constituency, so they provide them better services. And we can see the same thing in terms of distributing funds between the center and the geographical periphery. While the sick funds should be responsible for providing services at the same level at the periphery and at the center, they have a perverse incentive to put much more money in the center because there is more competition, because people are less, there are people who can buy the extra services that the sick funds are selling in order to make ends meet. So those are the 3 kinds of privatization of healthcare taking place within a universal single-payer system. It's still, in my opinion, the best of system, a universal single-payer system, but in how to say, unfavorable political conditions, even a universal single-payer system can be privatized, or at least partially privatized. Yes?
So, thanks. I have a couple questions. But first one is you mentioned, or actually you mentioned earlier that ability to pay the tax has been completely separated from ability to pay, or ability to get care. But how about ability to pay the co-pays? And do they have what we have here, at least some form of they're going to treat everybody, and even if they bill you afterwards and you end up going bankrupt, at least you're going to get treated and stabilized. Is that also true in Israel? And what happens in those situations when people can't pay all the extra fees and co-pays and everything else that's being put on them, even if they have insurance?
Co-pays are not for major interventions, nor for hospitalization.
Okay.
Co-pays are for drugs and for outpatient visiting of specialists and medical imaging. Now, we have surveys done by the Central Bureau of Statistics and the Israeli Medical Association showing that among the 20% poorest population in Israel, up to 30% report that during the last year they didn't buy all the prescription drugs prescribed by their physicians because they didn't have the money to do so. So yes, we don't see people not getting major surgery. And it's also true that co-payments have a cap. They have a cap of something like $35 per person per year. So there are not high co-payments. It's true. You are laughing, but in Israeli terms, there are still co-payments. And for the 20% poorest population, sorry?
Does a deductible exist or not?
No.
Okay.
But I want to add to Dani that there was a kind of study conducted at the Central District of the General Sick Fund when they actually, for the people suffering from chronic condition, they brought the money from other sources, and after 2 years, in terms of health outcomes, there was an improvement with those that actually were not paying, because people were sometimes you need to choose between buying, especially for the elderly, buying food or not. There is a committee now in the Ministry of Health, and Physician for Human Rights was a bit behind the scene also, to have, it is quite clear that this is an impossible situation, what Dani described, with the co-pay. We're talking about managed competition, but when all 4 sick funds are raising, it's like the banks, they're raising the co-payments, it looks a bit mysterious that they're raising it also the same rate all the time. So there is now a government committee that, especially following this study, that maybe will abolish.
Yes, I wanted to come back to the point you made early in your talk about neoliberalism, and I'm not sure everybody here, this is not a term that is as widely understood in the United States as it is in Europe or in Israel. So maybe you could just comment on what that means. But in general, neoliberalism has a couple of goals. One of them is to reduce total expenditures for social purposes like this, as a way of keeping more funds flowing to businesses which are seen as the productive arm of the society and the economy. And secondly, reducing government expenditures. And the shift to the private sources of funding away from employer contributions would seem to be a very key part of that. And also back to your point of why privatization tendencies would not increase expenditures overall would seem to be associated with shifting to increased personal contributions from people, because people restrain their own spending under those circumstances. We see that all the time. Could you comment on that? Is that
yes.
a pattern you see?
Concerning the first question, concerning the welfare state and especially healthcare, the idea of neoliberal policies is reducing state expenditures as much as possible in order to reduce taxes, in order to allow more money to flow to productive investment, and also because there is a kind of credo, almost a religious credo, that everything done by the business sector will be more efficient and better than than by the public
We're a little
sector.
familiar with that.
So in Israel, which has had a very strong public sector, this shifting included the commodification of the welfare state. So services that were provided on basis of government provision and need, they are provided now as part of a commercial relationship. Now, concerning the second point, the percentage of budget going to the social expenditures in Israel has decreased systematically and steadily along the years, and this that has also enabled a significant decrease in taxes. Income taxes went down in 20 years from a higher tax of 60% to a higher tax of 40%. A corporation tax went down from 61% of income to 29% of income in 20 years. Now, this has allowed a growth of the economy, but with a decrease in the quality and quantity of money available for public sector. So this is, in a way, the consequence of tax reductions. Now, they have managed to limit the increase of the national health expenditure because some people don't pay for health. This. And the second point is that the treasury officers, which are aware of the possibility of decreasing governmental expenditures but increasing national health expenditure, which is what happens in the United States, try to limit the extent of private services. For example, they are fighting against physicians in order not to allow private services provided in public hospitals, because they know that that will increase the national expenditure in health.
I want to add just one sentence in order to problematize things. So, of course, the United States in many ways is the exporter of neoliberal ideology. But what is happening in Israel is I think, very complicated, because on one hand, as Dani really nicely showed, that we have these neoliberal ideas, and Benjamin Netanyahu is probably the main architect. He claimed that Thatcher and Reagan are his heroes. So in terms of the philosophy of the economy. But on the other hand, Israelis are not suspecting the government, and now I'm talking about, for example, like things like mass vaccination, or that even expecting the government to be responsible for the health. So that's a major difference in our culture. So this is much more like the European, and it's also stemming from the social medicine ideology, from Hadassah and from the General Sick Fund. So it's so you have this neoliberalization, but you still have this kind of community, or also expecting the government to do certain things. Of course, it's more complicated regarding also question of security and the role of the government.
We would need another hour, but Nadav is right. 60% of the Israeli public consistently for the last 20 years consider that health and education should be provided by the state and public
are similar.
So there is a strong public support for public medicine against what is happening. Yes.
Just wondering about how they do the drug purchasing. Do they buy the drugs for the whole country and then break it down, or is it the French system?
Each of the sick funds
negotiate
So the
their
government
own.
doesn't get involved in that at all.
So
The government's not involved in
only regulating.
Only regulating.
Yeah, how has the physician's income changed with privatization?
Well, it has increased.
By how much?
Yes, but it's only relevant for the elite of the profession.
Yeah.
Elite surgeons and elite by far, because they are the average income for a physician in the public system is something like $80,000 a year.
Primary care, are they suffering?
There's no difference. There's no significant difference.
Yeah.
And people going private, they can charge $10,000 for a surgical procedure. So for the elite of the profession, it has really high rocket. Up to the point that, for example, the hospital, which is affiliated with our university, is paying very prominent chest and cardiac surgeon something like $40,000 a month. Yes, $30,000 a month in order for him to
but that's
remain to be a full-time.
But that's relate also to the question of center and periphery.
Yes, also
and
because
yeah, it's 1 hour from Tel Aviv, but it's considered periphery.
Yeah.
So coming to Soroka is the hospital related to Ben Gurion.
So
just struggling to keep
good professionals
at the periphery. So I want to thank our guests, Dr. Dani Filc, Dr. Nadav Davidovitch. We have a relationship that we have already